Yeah, let's do that. But then you might not be able to flip your pages, but it's okay.
I got 2 hands. Or Liz will flip it for me. What do I just press this?
Oh no, it's recording now.
Oh,
It's good. It's okay. I can just a minute though. All right. Good afternoon, everybody. I'm Sadie Dindy, and today I'll be discussing an article titled "Occupational and Physical Therapists' Use of Interpersonal and Interpersonal Emotion Regulation Strategies," written by Dr. Ayana Horton, David Holman, and Gail Hipson. I felt that emotion regulation was a great topic to discuss because of the importance of regulating our own emotions and the emotions of others, which is essential when we're trying to build therapeutic relationships. However, there has been little research on what specific emotion regulation strategies should be used during patient interactions. So what is emotion regulation? By definition, emotion regulation is the process of regulating the occurrence, magnitude, and duration of emotional responses. As I just mentioned, emotion regulation is very important when building therapeutic relationships with patients because a therapist's display of emotions and behaviors can assist patients with understanding the professional's thoughts, feelings, and intentions. So as healthcare professionals, we must learn to use proactive emotion regulation strategies and reactive emotion regulation strategies during patient interactions. Proactive emotion regulation strategies address anticipated emotions, whereas reactive emotion regulation strategies address experienced emotions. This distinction is important because research has shown that proactive strategies tend to be more effective than reactive strategies. Because anticipated emotions explain and guide emotion regulation behavior more than experienced emotion. But proactive and reactive strategies can be further separated into interpersonal and interpersonal strategies. Interpersonal emotion regulation strategies regulate one's own emotional responses, whereas interpersonal emotion regulation regulates others' emotions. Emotion regulation strategies play an important role in the therapeutic process, but little is known about how therapists use specific interpersonal emotion regulation strategies during patient interactions. Research on interpersonal emotion regulation at work is sparse, especially in healthcare settings. The small amount of research that does exist focuses on how using interpersonal emotion regulation correlates with the therapist's personal resources and effective experiences, so not the therapist and patients. Studies on intrapersonal emotion regulation in OT are lacking, and there's only one study that's focused on PT. Previous studies have argued that people use intrapersonal emotion regulation strategies both proactively and reactively. However, studies of interpersonal emotion regulation strategies have not drawn a distinction between proactive versus reactive. The lack of focus on proactive use of interpersonal and intrapersonal emotion regulation strategies has been surprising due to anticipated emotions having a direct impact on self-regulatory behavior, whereas experienced emotions have an indirect impact on self-regulatory behavior. But the use of emotion regulation strategies is context dependent, which means that different strategies can be appropriate or inappropriate depending on the context. So to address this knowledge gap, this study utilizes a semi-structured and unstructured interview, as well as non-participant observation techniques to understand how therapists use specific intrapersonal and interpersonal emotion regulation strategies during patient interactions. The guiding theory behind this research article is the process model of emotion regulation. It is the most prevalent categorization of interpersonal emotion regulation strategies. This model proposes 5 types of emotion regulation strategies that are distinguished by the point in the emotion generative process that they have a primary impact. And these types would be discussed later in further detail. So we've discussed what emotion regulation is and the difference between proactive versus reactive emotion regulation strategies. Let's further break down the specific types of proactive versus reactive. As you can see in the diagram, to the left is proactive emotions, which we know are anticipated emotions. So antecedent focused emotion regulation strategies lie within because they occur before an emotion happens. Response-focused emotions lie within reactive emotion regulation because they occur after an emotion happens. Here is a table that takes a further look at the 5 different types of emotion regulation strategies mentioned from the process model of emotion regulation. This table describes how all 5 strategies are used interpersonally to regulate one's own emotions. The first one, situation selection, ensures that one will be in a situation that promotes the desired emotions. So this would look like choosing to engage or not engage in situations to promote desired emotions and avoid undesired emotions, or avoid interacting with patients who provoke negative emotions. Number 2, situation modification. This is used to change the situation for the purpose of promoting the desired emotions. This would look like steering interactions to avoid negative emotion, involving efforts to prepare practically and emotionally. Situation selection and situation modification are antecedent focused / proactive strategies because they are used before any emotion is experienced. Number 3, attentional deployment. It attempts to direct or redirect one's attention to influence one's own emotional experience. This would be ignoring negative emotional events that are directed towards you. Cognitive change or cognitive reappraisal is modifying how one thinks about a situation for the purpose of promoting the desired emotion. So this would look like not taking personally a patient or family's negative behaviors towards you. Give yourself permission to feel negative emotions and just remind yourself of your scope of practice and your responsibilities. Number 5, response modulation. This is used to directly influence the experiential, behavioral, or physiological aspects of an emotional response. So you could hide your frustration, take a deep breath to manage anxiety, or hold back tears. Attentional deployment, cognitive change, and response modulation are all response-focused or reactive strategies because they are used after the experience of an emotion. These strategies will be discussed further in detail with specific scenarios on how to use each one later in the presentation. So this article was a qualitative study that used constructivist epistemology, which means that the knowledge gained is perspectival. The study was approved by the local IRB and was conducted in 2 stages. In stage 1, semi-structured interviews with patients and therapists were conducted. During these interviews, therapists were asked to tell a story of a therapeutic relationship they had recently experienced or were currently experiencing in order to highlight emotional events that occurred, the resulting emotions, and the emotion regulation strategies they used to address those emotions. Stage 1 of data collection helped inform stage 2. In stage 2, a fine-tuned thematic template and interview schedule were used. Data gained from unstructured observation of patient therapist dyads during their interactions and from semi-structured participant interviews with each dyadic partner interviewed at the end of the relationship were used to examine the participants' perceptions of how they use emotion regulation strategies during therapy interactions. Dr. Ayana Horton, who wrote the article, observed each dyad during their treatment sessions from the first session when they initially met to the last session when the patient was discharged from therapy services. The number of treatment sessions observed varied for each dyad, but ranged from 2 to 9 sessions. The observations were completed in person, with the observer seated in the clinic within hearing distance of the dyad being observed. An audio recorder was used to record dialogue. During the observations, the observer was looking to witness events that may cause emotion and notice how each dyadic partner responded to those events. The data collected through observation was not analyzed. It was only used to inform the participant verification interviews. During the participant verification interviews, patients and therapists were asked informed questions about interactional dynamics that occurred during the therapeutic relationship. Stage 2 of this study was built upon Stage 1, using methodological triangulation to cross-verify the data collected and pilot studies to fine-tune the data collection process. Member checking was used to ensure interviewers' understanding was in line with the participants' understanding. And a reflective journal was also used to record assumptions, actions, and rationales for those actions. The participants were recruited using purposive sampling from 3 hospitals and 1 clinic in the United Kingdom. During Stage 1, 9 physical therapists and 13 occupational therapists participated. Of these participants, 19 were female and 3 were males. All therapists ranged in age from their 20s to their 60s, who all worked in various specialty areas such as musculoskeletal, accident and emergency, and neurology. They ranged in years of experience from 1 year to 35 years. It's important to note that participants from Stage 1 did not participate in Stage 2 and vice versa. During Stage 2, 14 dyads were recruited from hand therapy clinics in London. 3 PTs and 5 OTs participated. Of these participants were 7 females and 1 was male. However, some of the 8 therapists participated in more than 1 dyad. The data was analyzed using King's template analysis in in vivo version 10. Data analysis began with formulation of an initial template that consisted of codes based on prior research. Relevant sections of each transcript were coded using King's description of the process as a guide. As thematic codes emerged from the data, they were incorporated into the template. In this way, the thematic codes on the template were fine-tuned because they were added and deleted until an accurate representation of the themes emanated from the data. The data was collected and analyzed simultaneously as well as conducted in repetitive cycles. Each cycle of data collection and analysis benefited from an increasingly fine-tuned template and increased level of familiarity with the data. Because the data from both Stage 1 and 2 of data collection focused on understanding therapy's use of emotion regulation strategies, they're reported together, but only data relevant to the therapist's use of emotion regulation strategies are reported in the article. The findings from data analysis showed that therapists used a wide range of interpersonal and interpersonal emotion regulation strategies when interacting with patients. These strategies were used both proactively in anticipated of an emotion or reactively in response to an emotion. This table explains how the 5 types of emotion regulation strategies described in the process model of emotion regulation are used to regulate therapists' negative emotions in different scenarios interpersonally. Most research on interpersonal emotion regulation in the healthcare field has only identified the broad categories of interpersonal strategies rather than detailing the specific strategies that healthcare professionals use. But some studies have described specific strategies such as identifying communication barriers, seeking support or digging deep within oneself. According to Smith and Kline, healthcare workers use strategies to emotionally distance themselves so that they can deal with undesired emotions. They found that healthcare workers use derogatory humor to dehumanize their patients and only focus on the medical aspects to avoid dealing with the psychosocial aspects of their work. Hammond and Cage found that healthcare professionals use interpersonal emotion regulation strategies such as getting support from family, venting to colleagues, calling into work to check on patients, and participating in distracting activities. Beginning with situation selection, therapists can choose to not engage in situations and avoid interacting with patients who provoke negative emotions by exchanging patients with another therapist or therapy student. In the example provided, this OT explains that she didn't feel like she could work with that he did. This OT explains that he felt like he couldn't work with the patient, so the patient was treated by another one of her colleagues. In situation modification, therapists try to steer their interactions with patients in order to avoid negative emotions. Therapists do this by preparing themselves practically and emotionally before working with the patient. In the example shown, this OT wanted to be prepared for the treatment session, so she looked into the patient's background to see what illnesses she was dealing with and the family dynamics to have somewhat known expectations of what could occur so that she could appear competent. In cognitive change or reappraisal, therapists tend to modify how they evaluate a situation to promote the desired emotions in order to prepare for treatment sessions. Therapists use cognitive change to protect themselves, maintain their professionalism, feel better, and to be able to get their job done. In the example, this PT tried to not take it personally when a patient displayed negative behaviors towards her. Another PT in her 20s with 3 years of experience mentioned that sometimes you can only do what you can do, and even though it sounds bad, you just have to be at peace with that. In attentional deployment, therapists ignore negative emotions such as a patient's display of anger directed towards them. In the example, the PT explained how distracting him or herself by redirecting his or her attention into something else when a patient displayed anger towards them. Another therapist, an OT with 6 years of experience in her 20s, explained that certain frustrations now bounce off her back because she can't influence them and there's no point in worrying about things that she can't influence. Lastly, in a response modulation, therapists attempt to hide their frustration, hold back tears, and take a deep breath to try to manage their anxiety. In this example, the PT mentions how you don't want to appear sad in front of your patients because, as mentioned previously, a therapist's mood, feelings, and intentions can directly affect your patient's emotions. An OT with 7 years of experience in her 30s discussed that if you are internally frustrated, don't let it out because if you get really angry with your patient, that would not accomplish anything. This table explains the specific interpersonal strategies therapists use during patient interactions. Therapists reported that regulating their patient's emotions is a vital part of their job, and at times regulating their patient's emotions took priority over therapeutic interventions because the patient's emotions influence their ability to take part in therapy. Altering the situation involves changing or modifying the situation to influence the emotional impact on the target. In this example, the patient made a comment about the therapist being physiotherapist, so the therapist made light of the situation by making the comment more positive so that the patient did not feel awkward. Another example of altering the situation was when a PT stated, even though I was going to see the patient as a PT, we didn't necessarily do any PT sessions. It was more of us talking and letting her deal with her emotions so that the next time we come, we can do the PT session. And this was a PT of 13 years of experience in her 40s. Altering the cognitive meaning. is used to influence a target's emotions by helping them to think differently about an issue or situation. In the example, the PT is explaining to the patient the reasoning behind therapy and to assure him that it's not to embarrass him, but to help him understand what he needs to improve on and realize where he's at in the process of recovery. Another example of this was when an OT with 2 years of experience in her 20s discussed how she tells her patients up front that certain decisions are not up to her, even though it's not true all the time. It's a way to avoid patient anger if she makes a decision with which the patient doesn't agree with. It's important to note that often the cognitive meaning of a situation are often used when patients are feeling sad about their lack of functional independence. Always try to encourage the patient to think about incremental improvements they have made instead of dwelling on how far they are from their rehabilitation goals. Altering attention. This is used to divert the target's attention to influence their emotions. In the example, you can see that the OT wants to switch the patient's mindset by being playful, interacting with their family, and just getting to know the patient overall. This is altering the patient's attention so that if they are in a bad mood, you can try to redirect their attention away from the stimuli that is causing the patient's negative emotions, such as the patient's uncertain future functional status or decline in functional status. Other therapists in the study reported that using small talk helps to take the patient's minds off taxing or painful therapy. One therapist explained that although she allows her patients to express their worries, she tries to prevent them from ruminating on those worries by refocusing the patient on the task at hand. She stated, if the patient is tearful, I'll listen. I'll be respectful and understanding, but then I'll move on by saying, that's okay, that's that, so how can we move on? Modulating emotional response. These are actions used to change the target's current experience or expression of emotion. In general, therapists in this study felt that patients had the right to feel negative emotions, and for this reason, they did not try to encourage patients to suppress negative emotions unless the emotions were particularly intense and directed at the therapist. In the example, you may notice that the PT apologizes for having a conversation in front of the patient that didn't make him happy, which is an attempt to change the patient's current experience. Another example of this is when a PT described how she attempted to regulate her patient's emotional expressions by setting and enforcing boundaries regarding which emotional expressions were appropriate and which were not. The PT stated, I think a large part of it was building boundaries and letting the patient know where the boundaries lie in terms of what he could and couldn't do. So you can say to the patient, I'm not going to accept it. If you're going to shout, then I'll come back when you calm down. According to Hochschild, surface acting are strategies used to maintain professional composure and de-escalate tense situations. Some examples include venting, switching off, crying, seeking support, eating, exercising. Here's some other examples that were said in the article. I said to my manager that I've been over backwards to help this family, and this is what I get. I exercise because of work, I think more than anything else, and probably at times have a glass of wine. This is the first research study to demonstrate the proactive use of interpersonal emotion regulation. Similar to previous studies, this study found that therapists may use more than one emotion regulation strategy at once. The use of interpersonal emotion may start before the patient-therapist interaction and continue long after the precipitating emotional event to regulate residual emotions. This study makes an important contribution to understanding therapists' proactive and reactive use of emotion regulation strategies. This distinction is important because research has shown that proactive strategies tend to be more effective than reactive strategies. As mentioned previously, research has demonstrated that proactive strategies tend to be more effective. To fully understand emotion regulation behavior, more research is needed on proactive interpersonal and interpersonal emotion regulation. Some limitations of this study. Semi-structured interviews are useful to assess participants' perceptions but may be limited by the participant's memory, understanding of the topic, and willingness to disclose information. The use of observation combined with participant verification interviews and stage 2 data collection mitigated some of these limitations because of asking questions that were based on observations may compensate for any deficits in participants' understanding or jog their memory. Using observation introduced additional limitations because participants may act differently when being observed. Also, the nature of some emotion regulation strategies makes them difficult to observe. As with all qualitative research, the generalization of the results is limited to the specific context in which the research was conducted. Some implications for occupational therapy practice would be providing training on emotional regulation, focus on the emotional aspects, and reflect on the use of emotion regulation strategies. OT and PT employers and educational programs can provide training to help therapists and students improve their ability to use interpersonal and interpersonal emotion regulation during their interactions with patients. Researchers can focus more on the emotional aspects of the therapeutic relationship to better understand relationship development, maintenance, and breakdown. After emotional events, OTs and PTs can reflect on their use of emotion regulation strategies and the associated outcomes to begin to understand how they can best regulate emotions during patient interactions. In conclusion, OTs and PTs use a wide range of intrapersonal and interpersonal emotion regulation strategies before, during, and after interacting with patients, often using more than one strategy at once. This research article makes an important contribution to understanding of emotion regulatory process in naturalistic rehabilitation contexts. And those are my references. And thank y'all for your time.